All right, welcome everybody. We're going to give just a few more seconds before we officially start things. Okay, greetings. My name is Butch DeCastro, and I'm the Associate Dean for Diversity, Equity, and Inclusion for the University of Washington School of Nursing. And I welcome you all to this webinar on abortion access and reproductive justice, sponsored by the University of Washington Health Sciences Schools. In late June 2022, Dean Azita Amami of the School of Nursing, Dean Edwina Uehara of the School of Social Work, and Dean Hilary Godwin of the School of Public Health issued a joint statement in response to the June 24 U.S. Supreme Court decision that overturned Roe v. Wade, giving individual states the power to make decisions about the legality of abortion in their jurisdictions. In that statement, they alert that millions of people across the nation will directly feel the impact of this decision on their health, reproductive rights, financial stability, and general well-being. That statement goes on to note that here in Washington, access to abortion is protected under state law. However, many other states in the United States are likely to ban or greatly restrict abortion. And that from a population perspective, the impact of SCOTUS's opinion will disproportionately fall on those with marginalized social status and those with limited financial means who may not be able to travel to states that legally provide abortion services. Subsequent to that statement, the deans across the 6 University of Washington Health Sciences schools, that's dentistry, medicine, nursing, pharmacy, public health, and social work, agreed that providing information and perspective about abortion access and reproductive justice to health professionals in clinical practice as well as the academic community would be helpful. And today we bring together experts in this area of practice, education, research, and advocacy to provide just that. In alphabetical order by last name, I introduce Dr. Molly Altman, Assistant Professor in the University of Washington Seattle School of Nursing, Professor Donald Downing, Clinical Professor in the University of Washington Seattle School of Pharmacy, Dr. Meghan Eagen-Torkko, Associate Professor in the University of Washington Bothell School of Nursing and Health Studies, Dr. Monica McLemore, Professor in the University of Washington Seattle School of Nursing, and Dr. Sarah Prager, Professor in the University of Washington Seattle School of Medicine. I also introduced Yazaman Zia and Taylor Riley, both graduate students in the Department of Epidemiology of the School of Public Health, who will be facilitating discussion around questions that have been submitted in advance for this webinar. On behalf of the Health Sciences Schools Deans, I thank each one of them for their time and effort to participate in this webinar. And to start things off, each of our panelists will speak for a few minutes on a specific aspect of abortion access and reproductive justice. Then we will get to the submitted questions for panelists to respond to. Dr. McLemore, we turn first to you, then I will leave it to you to call on the next panelists.
Good afternoon, everybody, and thank you so much for being here. I use she and her pronouns, and for those who know me, I'm myself on all social media platforms. I have a million things to say about abortion, family planning, contraception, reproductive justice, where we're at and how we got here. In order to maintain time, I have prepared some written comments, so I'm going to read those. Thank you for being here and thank you for engaging around this incredible topic. Let's start with reproductive justice. For people who know me, I am a huge person that needs clear definitions. So this one comes from our piece that I led in the Harvard Law and Policy Review that was published in 2020 with 30 Black and brown women and non-binary scholars from around the country, clinicians, researchers. We defined reproductive justice as a theory, a praxis, a strategy. It's grounded in 4 simple principles, building on the Sister Song definition. Simply put, reproductive justice posits that every person has a human right to decide if, when, and how to become pregnant, and to determine the conditions under which they will birth and create family and kin. Every human has the human right to decide they will not become pregnant or have a baby, as well as have all the accessible and available options to prevent or end pregnancy. Every individual has the human right to parent the children they already have with dignity and all the necessary social support, safe and healthy environments and communities without fear of violence from any individual or from the government or any state. And finally, individuals have the human right to disassociate sex from reproduction, as healthy sexuality, pleasure are essential components to a whole human life. And this affords us different opportunities to have conversations about consent. We are at a pivotal moment where everything we've ever valued in public health, and reproductive rights is up in the air. Many of the proxies that we use to assess maternal child health and reproductive health have been rendered almost meaningless by the Dobbs decision. For example, my good friend, Dr. Joy Queer-Perry, has always pointed out that marital status is a useless proxy because when two poor people decide to get together and parent, you now have three people attempting to live on the wages of two poor people. Similarly, early entry to prenatal care will need to be reimagined in the context of Dobbs and the loss of Roe. It has never been precise enough to capture that you may have spent months or longer traveling across state lines to receive a wanted abortion that you were unable to obtain. So despite the fact that you may have had an ultrasound or seen a provider, a medical assistant, talk to a counselor or a nurse, somehow that doesn't count. This is one of the many reasons why we need to operationalize reproductive justice along with reproductive health and reproductive rights. Quickly before I end, because I want to be able to get to as many questions as possible and have a really great dialogue, I want to make 3 points. First, if you are grieving the loss of Roe because its 50th anniversary would have been at the end of this month, please do that. But recognize that the emotional work that surrounds that is not conducive to those of us who are trying to plan in the now and plan for the future. Retrofitting the world for Roe cannot be the lone option given the unintended consequences of Dobbs, because we've had several wins prior to and post Dobbs that I and many other reproductive justice leaders around the country have been involved in. When you think about the restraining orders in Georgia, the codification of abortion in Kansas by vote, in Minnesota, where I provided the lead expert testimony, or South Carolina most recently with a temporary restraining order. Second, if you have opportunity to activate people around abortion, please do so out of human rights, bodily autonomy, and love. This is what reproductive justice is about. Co-opting the language of war and battles and other terminology that was developed by anti-abortion strategists is not helpful and it's not accurate. I've done multiple studies on abortion, and abortion is messy. It gets at existential and actual complicated concepts that are key to human lives. Keep it about the people that we serve and not procedures. Finally, when planning access and services, consider harm reduction approaches that assist people around the country, while also dreaming and building about the kinds of supports necessary to get pregnant, capable people the care that they seek and the care that they deserve. I look forward to a much deeper dialogue, and I'm going to turn it over to my colleague, Dr. Sarah Prager, who's going to talk with us a little bit about what we're doing at the University of Washington clinically to ensure abortion access. Sarah?
Thank you, Dr. McLemore. I appreciate it. And I also am going to try to keep my comments relatively brief, but hopefully that's going to allow for a lot more questions. I want to speak to what is happening in the state of Washington as well as at the University of Washington so that people have a little bit more context about what this means within the greater context of the Dobbs decision nationally. So Washington state has long been one of the states that has allowed abortion to be a normal part of healthcare and is what we consider to be an access state. And I want to just sort of clarify that in Washington state, we consider abortion to be healthcare. It's not exceptionalized. It still is exceptionalized, I should say, but much less so than in many other places. And I and others on this panel, we kind of reject the language that is sometimes used in other places about less access states or least access states or no access states. And instead, we encourage you all to also consider those states to be forced pregnancy states, not no access to abortion states, because that's actually what the reality is in those places. So in Washington, we haven't had and currently do not have many or any of the restrictions that we see in other places, like we do not have a waiting period. We do not have special regulations for abortion clinics that exceptionalize care that is happening there. We do not have a specific script that needs to be read to patients, typically including inaccurate or just simply lies. We do not have special rules around limiting access for minors. There's no parental notification or consent. However, I think we often feel pretty smug about what our abortion access is in Washington state. And I would encourage all of us to feel very grateful that we have the access that we do, and then not feel smug, and instead feel activated to continue fighting to expand that care. So some things that we don't have, we don't have access to abortion for anybody. And that means that the way our law is written, it can be interpreted to have some gestational age limits, which is not true in certain other states. So it's not really just up to the patient and her provider, because there is at least this threat of illegality at certain gestational ages that remain a little bit undefined. We also have a significant issue with mergers with Catholic healthcare systems in this state. So more so than almost anywhere else in the country, we have a predominance of hospital beds in our state that are owned or controlled by the Catholic healthcare system. It's over 50%. And reproductive health, as well as LGBTQ care and end-of-life care, has never happened in an evidence-based way in Catholic healthcare systems. And so that's currently true for 50% of the Washington state, actually over 50% of the Washington state population. And so Dobbs has kind of just codified that on a national level. And then I also just wanted to say that there are extensive geographic limitations to access to care in Washington state. So if you live in Seattle, then there are many people around who can provide an abortion. Although, again, given the Catholic healthcare system, there is one hospital system, which is the University of Washington, in the Seattle area, that actually is secular and provides abortion care. But if you live out on the Olympic Peninsula, if you live in Eastern Washington or many parts of Northern Washington state, access to abortion care is actually quite challenging and can involve driving many, many miles in order to be able to access that care. So I wanted to hone in on what's happening at the University of Washington a little bit too. We do follow evidence-based abortion practices and provide abortion care at the University of Washington up to the limits of the law. And I do think that's something that we need to be really proud of. We also allow for what the state also allows for, which is an expanded definition of who can provide abortion. So it's not just OBGYNs or family medicine doctors, but also nurse practitioners, physician's assistants, midwives, and other types of clinicians who are properly trained can all provide this care within the UW system. We provide surgical abortion and medical abortion, both in an office setting, in the emergency department, and in an operating room setting, depending on a number of factors, including patient preference. And I will also say that we are actively trying to expand or I shouldn't say expand, but actively trying to establish a legitimate telemedication abortion practice at the University of Washington. Excuse me, there has been a group working on this actually for years. That work has been accelerated since the Dobbs decision, and I am very confident with that within the next month or so, we are going to have a functional telemedication abortion practice available through the University of Washington, which I think can be a game changer for a lot of our patients living remotely from our clinics or just who don't want to come into the clinic. So that's just a little piece of what we currently offer. And I think there are nuances that I'm happy to get into more with questions, but I am going to stop there for the moment and pass the mic on to Meghan.
Thank you, Dr. Prager. So one of the things that Dr. Prager touched on that I really want to come back to is the idea of Washington as a high access state, when in reality, that's really not the language that I would choose to use. one of the things that is most important to remember is that, like COVID, Dobbs did not invent a substandard healthcare crisis. Instead, like COVID, it really amplified the inequities that already existed. And as Dr. Prager said, one place in which this is really clearly evident is in management of pregnancy complications. So we like to think of Washington State as one with ample reproductive health services that will provide appropriate care in the case of miscarriage or other pregnancy complication. But as was noted, we're a state in which over half of all hospital beds are in Catholic-affiliated healthcare facilities and subject to the directives for Catholic healthcare that were in place for decades before Dobbs. These limited or banned abortion, end-of-life care, gender-affirming care, and some contraceptive care. So what Dobbs did was it expanded these Catholic healthcare restrictions that already existed, including in Washington State, to secular hospitals in the states that used it to enact bans. Our hands are not clean in Washington State, especially in rural areas, but also in a lot of areas that we don't think of as rural, like, for example, Everett or the North Sound. So what this means is that under Dobbs and under the Catholic restrictions that previously existed, while there may be exceptions to the abortion ban that allows the procedure in life-saving situations, this really requires a provider to make a decision that can damage or end their career and their livelihood based on their interpretation of often intentionally ambiguous laws. So these are people who have spent, as many of us have, years or decades becoming providers. We support our families with our salaries, and what these abortion exceptions sometimes allow for requires us to make this decision, sometimes on the fly, about what is going to be covered under the exceptions and what is not. So this is going to lead to delays and denial of care. We know it's going to lead to delays and denial of care because it already is, and because we have 20 years of research in Catholic healthcare facilities in which providers are essentially forced to decide between providing appropriate care and risking a patient's life and health. Providers in many states are literally being required to decide how close to dead is close enough to fall under these exceptions. The implications for this go well beyond physicians or advanced practice clinicians, and they touch every person in an ER, in a labor unit, or in an OR. One of the things that is particularly concerning is the potential for moral distress that this can lead to. So moral distress is defined as a conflict between what is right and what is possible. It's a potentially career-ending harm. It's like an injury for a professional athlete. Enough moral distress can end your career as a healthcare provider because it's associated with post-traumatic stress disorder, depression, anxiety, and burnout, as well as an increased risk of leaving the profession. So in this post-COVID era, at a time when healthcare is really bleeding workers, Dobbs is opening that wound deeper. It is making us harder. It is making it harder for us to keep providers because we are subjecting them to harm. This is essential to consider because when these bills are passed, they're often passed with assurances that, of course, the quote unquote right abortions, life-saving abortions, will continue to be available. This is very soothing, and this is wrong. This is a lie. And it points out the major failing of having a hierarchy of abortion in which some are acceptable and some are not. In the end, abortion is healthcare. Healthcare is an essential human right. And limiting any of our rights to this puts all of us at risk, whether as providers, whether as patients, or whether as the person who shows up in the ER at a Catholic hospital with uterine bleeding and no visible pregnancy on ultrasound. So to ensure that we have enough time for questions, I'm going to go ahead and turn this over to Don.
Hello, everybody. Thanks for that, Megan. My name is Don Downing. I'm a clinical professor of pharmacy at the University of Washington. And I'd like to first address the fact that I think people probably can only guess at what role pharmacists might play in access to sexual and reproductive health services. So I'd like to dispel a couple myths and provide some new ideas about how pharmacists can be engaged. So for most people, their experience with a pharmacist is in a community pharmacy. And in 1996, the University of Washington School of Pharmacy, a colleague and I, developed a novel program for the country, and that was pharmacists as contraception prescribers, not just filling prescriptions, but actually initiating those prescriptions for women who would come into pharmacies in Washington State in evenings, weekends, holidays, typically when other services were closed. And we realized that a lot more women were coming to us, pharmacists in Washington State, than we anticipated, because prior to 1996, 2 years prior, only about 2,500 women a month came to get emergency contraception in Washington State from all the medical providers in the state. When pharmacists were trained to prescribe emergency contraception, we almost immediately were seeing prescribing for more than 2,500 to 3,000 women every month in community pharmacies in Washington State. And we became immediately the prescriber of over 90% of all the emergency contraception in Washington State. It's because we met people where they were. They didn't need to make an appointment. They could come in after school, after work, on weekends, and access this reproductive health service on their own time. And they came with autonomy and dignity and respect. So here we are today with the Dobbs decision, and we are looking at medication abortion provisions. And I'm sure most people who are on this webinar understand that the FDA just began to allow pharmacies to stock mifepristone in their pharmacies. The rules around that are new, and we're ramping up certified medication abortion providers, mifepristone providers, can also provide misoprostol. And we already have several national chains who've already publicly announced that they're providing it. But I wanted to go back a little bit to approximately 4 years ago, when I and other colleagues at the University of Washington initiated a small study that informed the FDA about why pharmacies could dispense mifepristone to women seeking medication abortions. And that is, we used a pharmacy at the University of Washington Medical Center, one of the clinics. And we also used a community pharmacy in Tacoma near Multi-Care Hospital, Tacoma General. And those pharmacists were dispensing mifepristone to women upon orders from physicians. The results of that study basically showed that it was safe and effective for women to not just get medication abortions directly from their medication abortion physician, but also it could be ordered, and they could take the directions from a pharmacist and take it home and have a safe and effective abortion. Recently, with the Dobbs decision, the importance of a pharmacist again came to mind with me about, could pharmacists prescribe medication abortion? And I'm pleased to say that I'm involved right now in a proposal we're looking for final funding for. We're always looking for funding, aren't we? That would train pharmacists to provide medication abortion, not just filling those prescriptions, but prescribing it. And so we'll be looking to initiate that project here very shortly, I believe. We're also working with tribal nations, around the country in trying to provide telemedicine abortion services, either through reservation services or through pharmacists, physicians, nurse practitioners, and others using telemedicine to prescribe medication abortion and having it delivered to patients at their homes. So even though pharmacy may be seen as sort of just somebody who takes orders, I'm going to argue that all of us who are interested in improving access to sexual and reproductive health services consider working with me and my colleagues in pharmacy to establish kind of novel new access points to healthcare that involve not just dispensing drugs, but initiating prescription orders. By the way, we're very proud of the fact that our school, because of our long history and work in sexual reproductive health services, we've just installed a vending machine on campus that provides emergency contraception and other sexual and reproductive health supplies. It's in the basement of the Odegaard Library in St. George, near a cafeteria in the basement. And we're looking at new sites around campus to also provide vending machine access to contraception, because we certainly, in this time of Dobbs decision, we need to improve access to contraception services in order to limit the number of people who might seek an abortion. So I'll certainly save time for questions, answers later. Let me hand it over to Dr. Molly Altman from the School of Nursing. Thank you.
Wonderful. Thank you so much. And thank you all for being here and engaging with us today. My name's Molly Altman. I use she, her pronouns. I'm an assistant professor in the School of Nursing and a nurse midwife by training. I have to say it's a hard act to follow with all of these amazing speakers. And as the closing member of our team here, there are a few things I want to focus on are really related to action. What can we do? And what are some potential avenues for us to move forward in this environment around abortion care and reproductive justice? So besides what everyone has shared in terms of the state of abortion care and reproductive health within Washington state and the country, and the great tips that Dr. McLemore shared around advocacy and action at the beginning, one of the main ways that we can move forward in this is through workplace development or workforce development, excuse me, and really making sure that we can expand access through the providers of care who will be interacting with patients through whatever experiences they require our services for. So as we do this, we need to really consider the significant impact that the people who provide care have on patients, that we all carry our own feelings, biases, assumptions, and ways of being in our interactions with people. And so having appropriate, equitable, justice-oriented education for healthcare providers and everyone on the healthcare team is essential for us being able to provide and expand access for equitable abortion care. So there are two main areas that I'd love to focus on through this. Again, feel free to use the Q&A function to post questions that you have that we'll get to after this. But the two main areas that I want to focus on, one is we really need to be focusing on interdisciplinary collaboration when it comes to providing abortion care. Historically, the way that the country was set is there were a lot of states that were physician only when it came to providing abortion care. And so that meant that advanced practice providers like nurse practitioners, nurse midwives, physician's assistants were not allowed to provide abortion. With the Dobbs decision, that actually has equaled the playing field a bit in that the states that have these restrictions no longer offer abortion. And so for all of the states that do, essentially, advanced practice providers can provide abortion, and we need the training to be able to support that. And so there are some really great opportunities for seeing how we can have that interdisciplinary and transdisciplinary work between advanced practice clinicians, physicians, pharmacists, social work, public health, to really make sure that we're providing care that meets the needs and goals of the patients that we're serving. The real key thing here is that there are currently no education programs that support advanced practice clinicians in learning procedural abortion specifically. And so that's one of the main gaps that we're hoping to fill at the University of Washington. We just received funding in the School of Nursing to support the Abortion Care Training Incubator of Outstanding Nurse Scholars, or the ACTIONS program, which was led by Dr. McLemore at UCSF. It has now expanded to us and NYU to really expand the ability to train quality healthcare providers and scholars within nursing. And the School of Nursing has also just initiated the first ever nurse-led abortion care training program as a graduate certificate within the School of Nursing. So, and this is actually something we're doing in collaboration with programs and institutions across the country who hope to replicate what we're doing and really find ways of expanding education opportunities for advanced practice clinicians. There's also a need for supporting workforce development across all disciplines. Healthcare providers are not the only ones who are interacting with patients and the people in which we serve. We also need to be providing education for nursing, for medical assistants, for front desk staff, for administrators, for security staff, for advocacy and engagement staff. We need to make sure that everyone who is going to be interacting with patients has received the training, the support, and the ability to really create an environment that is safe and supportive and inclusive for everyone who comes to our doors. And so there is a need for that level of education for everyone. And I don't want to forget community. We really need to be making sure that for folks who are in areas that are underserved, who may not have healthcare providers close by, or who are restricted due to restricted natures of healthcare systems in their area, that there are community resources that are supported and well prepared to provide services to folks who need them. So these are all really important ways that we can move things forward and support the patients that need support, the communities that need support. The reality, and this has been mentioned a couple times, abortion is an essential piece of healthcare, and we need to make sure that it's available if we're hoping to provide equitable and inclusive healthcare for pregnant, capable individuals, communities, and for our society. We're really well situated in Washington State to be able to equitably expand access through education and building up the workforce. And we also have a lot of influence on access within other states as well, particularly in partnering with our reproductive justice colleagues and others who are doing really important work across the country. So with that, I'm going to wrap up and hand it over to Yaz and Taylor for transitioning over for Q&A.
Thank you so much, panelists, for your excellent presentations and wisdom and expertise and experiences you've shared with us. We're going to transition to a great discussion with lots of questions and answers. I'd encourage all the attendees to please enter your questions in the Q&A box, and we'll get to as many as we can. We're going to start first with some questions that were submitted previously. And we'll start off with what is happening on a national level to expand and protect access to abortion care.
I'm going to go ahead and take this one because I think having a national pulse of understanding that there have been pieces in place for a while, anticipating the fall of Roe. This just didn't fall out the sky. I mean, people have known about this for at least a decade. And so I can state that there are several legislative strategies that are being led by All Above All, the ACLU, If, When, How Lawyering for Reproductive Justice, the Center for Reproductive Rights. There are many law firms that have been, shoring up the temporary restraining orders in different states, but there's also been trying to push specific to the Women's Health Reproductive Health Protection Act. Congress could fix, I say this on webinars all the time, but Congress could have fixed this if they wanted to. and really be able to affirm rights, that were afforded under Roe. So for folks, please participate in elections and vote because they matter. Because Congress actually could fix this if they wanted to pass a law, and the Women's Reproductive Health Protection Act is one of those places. I can also say that for people who are self-managing their abortions, if, when, and how, Lawyering for Reproductive Justice has put together several webinars to be able to protect patients and providers from criminalization. There's a toolkit that exists for individuals who do not want to end pregnancies under clinic supervision, however, still want to be able to have legal protections. There are toolkits that do exist. The National Network of Abortion Funds continues to provide practical and tactical support for individuals who are traveling to receive abortion care. We've seen the opening of a couple of nurse midwifery and physician partnership-led clinics, most recently in Maryland, Partners in Health, to really be able to expand access. And we are looking at mobile provision of abortion care. There's two different domains. Planned Parenthood started some mobile provision of abortion care. And then Dazon Dixon Diallo and the reproductive justice folks at Sister Song, Sister Love, and Sister Reach have procured a mobile van trying to provide HIV prevention and abortion access and a whole variety of sexual and reproductive health services using their new mobile van that is also nurse and midwifery led. I'm sure others have exemplars of where expansion is happening. Just realize with the loss of the federal protections of Roe, many of these processes are happening in a state by state and strategy. It also, I guess I would also be remiss not to mention All Above All, who is trying to repeal the Hyde and Helms amendments that do not allow for people to use federal coverage for abortion access, i.e. In the Indian Health Service, and people who use Medicaid in states where Medicaid has not been expanded under the Patient Protection and Affordable Care Act. And to also be able to shout out the notion that we've had some wins prior to Dobbs that weren't just around abortion. We expanded abortion in Boston, in Hawaii, in my home state of New Jersey. So there were places that were preparing for, and I actually prefer the language that Dr. Lisa Harris uses in Michigan, this idea that there are banned states and surge states. When you think about where abortion is banned and where people are seeing a surge of patients who are seeking abortions, I kind of like that language. And I think language is really particular now that we're in a place to shift the narrative about abortion care. I think we all should be attuned to the language that we use. Others?
Okay, thank you so much for that response. We'll move to the next question. What are some other ways to expand access to abortion care, specifically around self-managed abortion? Maybe there are folks on this call who are unfamiliar with that term. Can one of the panelists speak to self-managed abortion?
I'm happy to tackle that first if you'd like. So self-managed abortion is kind of a general term for managing abortion outside of a clinic setting. And that can look like a number of different things. That could look like somebody using aid access, which is sort of a physician or clinician overseeing an online abortion process. It could look like obtaining medications by themselves over the internet or getting medication from another country, something like that. It also sort of, or is used as a bucket term to include community-supported abortion care, which isn't really self-managed because it's happening with abortion doulas and or herbalists and or other people in the community who are really supporting a person through this process, but also not in a clinic setting. So Washington State has already done some work to support all of these types of non-clinic abortions, including Washington State just updated its abortion law, and that went into effect in June or July. I'm sorry, I don't remember exactly which month. I think it was July. And it included more support for anybody providing abortion care, including not licensed clinicians. And so that was actually a really important move to protect people who are getting abortions and providing abortion care. I talked a little bit about medication abortion. Telemedicine abortion is not really self-managed abortion, at least in the way that we think about it, because it is very definitely clinic guided, and it involves just, I mean, like somebody on the other line of something like this and directed counseling, et cetera. There was a question I saw in the chat about whether medication abortion can be provided to people out of Washington state. Right now, telemedicine in general is restricted to people who are within the state of the clinician. And so I can't provide telehealth on any topic to somebody outside of Washington state, and that includes abortion care. However, the restriction is that the person has to be physically located in Washington state. So that does give access for people coming into Washington state for their visit. And I can, the way we're setting this up is to be able to mail medications to any Washington state address. So that is still going to expand care, including potentially for people whose primary residence is not Washington state. I think there was also a question about whether UW, and I took that to understand maybe Hall Health is providing medication abortion. And my understanding is that there's a lot of interest in doing that and work moving towards being able to potentially provide that on campus. That is happening more frequently at college campuses across the country. And we certainly at UW Medicine fully support that and in whatever way we can. And also there are a number of clinics located very proximately to the campus that are UW and other that can provide this service as well.
Thanks so much, Dr. Prager. So our next question is Washington specific, and if some panelists could speak to what are the negative impacts post-Dobbs that we're seeing in Washington state.
Well, let me start off by saying I'm not sure how we're defining negative, because, if it's from the perspective of seeing an influx of patients, that is definitely inconvenient for the patients who are traveling, but I don't know that I would call that negative. So it would depend on what we mean by negative. That said, the same problems we had pre-Dobbs are the same problems we have post-Dobbs, right? So again, to Dr. Eagen-Torkko's point around rurality and people across our state not having equitable access, all the way to people who are trying to seek care in religiously affiliated institutions, whether or not they share said religious orientation or not. And then we have restrictions around federal dollars. So people who are in the military and people who are, on, reservations or other native lands, those restrictions still apply. And I don't think a lot of people understand that. That's why reproductive justice folks tried to get away from setting and really start to talk about people seeking care. Because, as we continue to think about what's possible, we want to also be able to start to really address this issue of disparities, to abortion access, just based on payer type and based on insurance and based on access to whether or not we have abortion funds that can help people to seek the care that they need. So at some point, we also have to have this broader discussion around, people's access to services being driven by who's paying for it. And so I don't think that there are new negative sequelae of Dobbs. I just think that they have been amplified by the fact that we've had a loss of Dobbs.
Can I expand on that a little bit? I think that, or some of the questions that I received immediately following Dobbs were, are we going to see a lot more people harmed or dying from unsafe abortion, from illegal abortion, from self-managed abortion, people taking matters into their own hands now that it's going to be inaccessible in many states? And my answer is we are going to see more people harmed or dying, more pregnant people harmed or dying, but not for those reasons. The reason that we're going to see more people harmed or dying is because pregnancy is always more dangerous than having an abortion, and continuing pregnancies is going to lead to more complications of pregnancy. So we are going to see more people harmed and dying from preeclampsia, from hemorrhage, from suicide and homicide, which are big players in pregnancy, and postpartum. And we're going to see all of those different things that are risky for people in pregnancy. We're going to see more of it because more people cannot access the abortions that they need. We already, just a week or two ago, there was data published that we're seeing increased suicides in reproductive aged people with a uterus in states where abortion is not accessible. And so this is not a hypothetical. It's already happening. And those are the harms that are, as Dr. McLemore said, amplified by Dobbs. These are not new, but they are amplified by this more extreme version of lack of access.
Thank you, Dr. Prager and Dr. McLemore. In the face of uncertainty regarding the constraints of the law for healthcare workers, how do you ensure that you're doing the best you can for your patients? And what resources can help healthcare workers navigate those similar uncertainties?
Let me address it just from the pharmacy perspective, because in looking at comments and feedback I've gotten already prior to this meeting, it's very obvious that all of us healthcare providers have to come together and work as a team for the best outcomes for our patients. And so it's rather amazing how many opportunities have been offered to me to have physicians and nurse practitioners, counselors, and others collaborate with the pharmacy profession in providing more comprehensive, safer, effective care. And so to me, it's that team-based care that makes all the difference. And I know there are probably more nuanced responses also, but it's really important for my profession to be part of the team and for us to work together.
This is where I think professional organizations as well as student organizations are very helpful. So, you know, when you think about students for choice, whether it's med students for choice, nursing students for choice, you know, there have been some guidelines and toolkits that have been put out. Similarly, you know, the American College of Obstetrics and Gynecology, the American College of Nurse Midwives, APHA has had statements out, you know, forever about ensuring reproductive autonomy and abortion access. So I think, you know, in a time when we have legislative uncertainty, and it probably would have been helpful for us to have one of our legal colleagues on here with us, it's important that you want to be able to, you know, engage with the policies and procedures of your employer, as well as ensuring that, you know, you understand what your legal rights are in the state of Washington. And, you know, right now that's tricky because we are trying to, you know, ensure that healthcare workers are protected. And at the same time, you know, we don't want people to be restricted or kittens are deciding to walk across my laptop. I warned y'all that was going to happen. Not wanting to know where to get information from is going to be really, really crucial. So understanding, you know, what your current legal rights are, and also getting really clear and really good advice in terms of understanding like what your employer is doing and how you can definitely engage within the parameters of the law in Washington state.
And to piggyback onto that, we choose our profession. That is a choice that we make. And I think that for us not to acknowledge that we have ethical responsibilities to our patients that are oftentimes uncomfortable and that oftentimes can place us at risk is not doing either our profession or our patients any services. I do not personally feel that conscience clauses are ethically acceptable. There are certainly people who disagree with that, and there's certainly a lot of legal protection for that. But one of the things that I think we really need to be very clear on as healthcare providers is that denying our patients life-saving or life-assisting care based on either our personal beliefs or our fears about the legal status of the role that we're in is not an ethically tenable situation. Doesn't mean that you have to do it, because of course, you know, people always have a choice about their behaviors, but I would really challenge us to think about, if we choose to do this work, are we choosing to do it? Or are we choosing to do it when it's easy?
Thanks so much. Thanks so much. So our next question is for Dr. McLemore. If you, attendee, had a question about strategies to speak about abortion alongside other bodily autonomy issues, such as gender affirming care.
Yeah, I mean, the language that we use when we talk about pregnant capable people or womb holders, people who have uteruses, you know, sperm producers, whatever language we're going to use, we want to be technically accurate. That said, as part of the Dobbs decision, the National Birth Equity Collaborative and a whole lot of other reproductive justice organizations signed onto amicus briefs making a very important legal point, coming at this from a human rights perspective. And that is that in the context of bodily autonomy, the only arbiters who can truly make any pregnancy-related decision, and Dr. Prager was spot on in reminding everyone, abortion, miscarriage, stillbirth, birth, these are all outcomes of a clinical condition that we call pregnancy. Pregnancy is actually the condition, right? So to act as though pregnancy in and of itself doesn't have any risk is actually quite wrong. And so the only true arbiter, the only person who has any say around what kind of risk they will or will not take on, of their own health is the pregnant capable person. That said, there was also a question that came up around the language that we use specific to pregnant people who don't necessarily don't identify as women, and that potentially can bring gender dysphoria forward. We need to be listening to patients and providing them the care that they are requesting. Specifically also going back to the comment around, should we be changing our birth control? And I would use the word contraception, contraceptive counseling for Black and Brown patients, if we want to use a reproductive justice lens. Well, that means starting with eliciting what those people have used in the past and what they want. And knowing that that is a patient, sensitive decision, a patient preference decision, and that they alone, as long as they meet medical eligibility criteria, and I'm going to CDC with a whole lot about reproductive justice people later on this month to talk about that. As long as they meet the essential criteria and have no health conditions that would contraindicate them receiving contraception, they should receive the method they would like, right? Now, Dobbs is not another place to create more patriarchal control of pregnant capable people because we're trying to protect them from pregnancy. They get to decide that. The people we serve get to decide what is best in their lives because they're experts by experience. So for me, the language that we use, it really matters because in a lot of times the historic language that we use isn't even scientifically or technically accurate. So as we continue to, that's why being with community, to Dr. Altman's point, is so crucial. They use language that I think is more effective for us to be able to really understand getting their sexual and reproductive health needs met, so they can meet their reproductive life goals over a life course, because they have to live with the consequences of that. And for too long, we've dictated public health policy on individual decision making, very similar to what we do with trying to address structural racism with individual level interventions. It's not helpful. So Dobbs has given us the opportunity to think really differently about these things. And one of those things is the language that we use to talk about and the context that we use to talk about pregnancy.
Excellent. We're loving this dialogue, and we have a lot of students on this call. So we're going to pose this question to all the panelists. How can individuals and students advocate and show support for access for abortion and educating others on abortion?
I can start this conversation. I think there are so many things that we can do, even if you're not directly involved in either education or getting actively trained or what have you. I think the first step in all of this is you need to make sure that you understand what's going on. Do some work yourself, understand the situation and the context, understand your own positionality as it relates to these topics. As we sort of mentioned at the beginning, abortion has been created to be a controversial topic that has a lot of opinions and thoughts. And the only way that we can really support productive conversations and advocacy is making sure that we understand our own assumptions going into this. So I strongly encourage everyone to take that as sort of the first step in understanding where you sit in all of this, in terms of your positionality, in terms of your understanding of what's going on. The other big piece here, that I would recommend folks do is be willing to step out of your comfort zone and speak up and share, especially with those who disagree with you. This is where it gets really tricky, because a lot of people are really used to only speaking in places where it's an echo chamber. You're talking to people who already agree with you and they understand these concepts. But where we're really going to have make a difference is when we're speaking with folks who have different views, and you can engage in dialogue and having conversation. That's where we can start moving the needle around some of these concepts. And the last thing I'll go to, because I know other people have thoughts on our panel, is stick with the facts. You know, there's so much that is emotionally tied to this topic that if you stick to the facts around the statistics, like we've mentioned numerous times, but this is something to hold on to. Carrying a pregnancy to term and giving birth is so much more risky than anything related to abortion, any type of abortion. That is a fact that is based in the evidence that you can hold on to. There are numerous other facts. Sticking with those types of information when you're sharing information around abortion access and abortion care in general are sort of key things that you can at least start with.
We're loving where this conversation is going. Any other panelists want to chime in here?
Well, let me just briefly state that I see in the Q&A there are quite a few students who ask how they can get involved in the contraception side of this discussion, and they should know that the ASUW leadership and Student Life are both deeply involved in improving vending machine access points and in supporting student access to sexual and reproductive health services. So it's been a pleasure working with them. But I would suggest students who want to roll up their sleeves and help out, consider contacting Student Life office, even the ASUW leadership. They're both looking for assistance. Thank you.
And nationally, please do your homework to figure out who's already organizing and who's already doing work. You don't want to replicate and do some of the redundant missteps that other folks have done. You know, the National Network of Abortion Funds is constantly looking for volunteers and practical and tactical support for abortion-seeking individuals. And so, they're a really great way to get involved. There are abortion funds across the country and, are really trying to get people connected to the care that they need. There was an activist training that the Abortion Access Front pulled together to really, for people who are new to the abortion conversation, to really give people foundational skills. There's a toolkit. They got a whole YouTube training series. People like Shout Your Abortion, the Abortion Care Network. There are like organizations that have been preparing for this who need human bodies to assist us. Make sure you're amplifying fact-based information if you're a social media user or a TikToker or a YouTuber. so that the only people who are not using these tools that are talking directly to people that we serve are not just bots, Nazis, bots, and trolls, and people, peddling misinformation and disinformation. So make sure you're amplifying scientifically relevant and clinically appropriate sources. And also, vote. I'm gonna keep saying that because, resource allocation in our country, whether it's human, money, time, or space, is really dictated by, voting. And if you don't vote and participate in the process, then, it's very difficult to think about how to engage you post, situations like this.
Professional organizations are a really, really important thing going forward as well. I can't speak enough to the need to have voices of people who support access to reproductive health and reproductive justice principles actively in professional organizations, because the reality of most professional organizations is that the people who show up are the ones who are going to drive policy. And if you have something to say, then you might as well say it, because it's usually just a few people who are speaking up at any given point.
Thank you all for this excellent advice and calls to action that we can all take up. We'll keep it sort of within the training and education space, since we have a lot of students on the call now. But Dr. Altman, you spoke a bit about this in your opening remarks, and I'm wondering if you could talk more about how to promote more education around abortion in healthcare training, and also in public health training and health sciences more broadly, so that we ensure that, we're talking more about abortion in all of our classes, not just a special class related to that.
Yeah, thanks for that question. There is so much that will not be covered as part of this webinar. However, I think the key pieces that I feel really resonate for me to share, one is that everyone has a role in this work, and there is room for and opportunities for education to support ensuring that there's equitable access to care, including abortion care and reproductive health care for everyone. And so every school, every program has the potential to include this in the work that they're doing. For folks who are hoping to be on the front line, so talking about sort of the health sciences fields, I know that we at the School of Nursing, at least, have been working on creating not only a procedural abortion training or sexual reproductive health care graduate certificate for advanced practice nurses who want to be directly providing both medication and procedural abortion care in Washington State and across the country. We're also hoping to expand to make sure that abortion care is included within the curriculum for all undergraduate nursing. The hope is to expand to associate's level nursing as well. We need to be having this in MA, like medical assistant training. We need to have this information in the hands of community providers who people interact with. And when we're talking about the reproductive healthcare space, we talk a lot about doulas. We talk a lot about lactation providers. They have a role in this space because of the amazing connection and continuity of care that's provided at that level that you cannot get in a formal healthcare setting. And so making sure that this information is provided so that people feel well equipped to have the resources and knowledge and education to be able to support the people who show up and need care and support. I think that's really where we're going and what we're hoping to do. I did see a question in the Q&A around people wanting to get engaged, undergraduate students wanting to get engaged. I think that there will be opportunities. And I think this is something, as at least in the School of Nursing, as we're creating programmatic structures to support education around abortion, we will be soliciting and asking for feedback and knowledge and wisdom that you all hold in terms of what you feel is important to be building these programs so it best supports the learners that we're working with. So there will be opportunities most likely to be sharing around what you want to learn and how you want to engage in this content. And really making sure that the education is built on an equity and justice framework. So this goes back to the question I saw in the Q&A as well around making sure that we really are looking at gender inclusive language. And like, this is a big issue when we're talking about reproductive health care, because the majority of language is focused in a very cis heterocentric way when it comes to pregnancy. And we are trying, at least, I think at UW, across the board, to try and change that script and make it so that we are using language that includes everyone who is accessing care, and that we're not unintentionally harming folks who engage in these services as well. So there are a lot of aspects to this, but I really see check in a couple of years, we're probably going to have a whole different slew of opportunities available across the university to support education around this.
Let me pick that up from there too, because I also want to put out there that, you know, having come from California, you know, the students were really responsible for increasing medication abortion access on college campuses. And, you know, users of student health services were very, very incremental or instrumental, in making that law a reality. So as we start to think through, you all want to get together and what is your collective brain trust? Because like you're in the age group of the people who are most impacted by this, right? So, and I think there's enough wisdom and creativity if we reject the false binaries around how abortion historically has been talked about, which is one of the beauties of reproductive justice, that if y'all got together collectively, you could think about new ways of plugging in and engaging around expanding abortion access. I do want to take on one of these important questions that is in the chat that says, what would you advise, staying on this training thing, what would you advise for those of us in training, nurse midwifery and women's health NP who are planning to go practice in states that have forced abortion to provide to the resistance? I apologize for using the war language in those states. I think you mean forced pregnancy. There are states that have a Black midwifery fellowship. Memphis, Tennessee is a perfect example of this, in the middle of the Rust Belt, run by Dr. Nakia Grayson, and she's brought in multiple midwives who are trained at the University of California, San Francisco, at Yale, at Hopkins, to really build out a hospital-based, a home birth-based, and a birth center-based practice where those midwives are providing all the care, you know, for the Black residents in Memphis, Tennessee. This is not something you have to create yourself. Again, this comes back to doing some of that, the reflection and the homework of understanding who's doing what where and how are they getting that work done? Because there's an incredible model of full spectrum, you know, Black midwifery led care in a city like Memphis, Tennessee. They have more expanded midwifery practice than many had in California for a long time. And they were able to work with their legislatures and work with their, you know, universities, work with the crisis pregnancy centers and other pregnancy help centers in their geography to really build out a model of care that is well respected and well trusted. So this isn't about approaching, you know, from a place of we want to go and, you know, serve in these, you know, serve again, these banned states. But it's really more about figuring out how the people who are working in those, you know, environments are thriving and doing relatively well. Feminist Women's Health Center, who is going under a strategic plan and probably a rebranding and a new name in Atlanta, Georgia, is another beautiful example of this, trying to operationalize reproductive justice within the clinic walls. And how do you do that, you know, in an interdisciplinary team-based way?
If I could build on that for a moment, or Megan, am I stepping on your feet? Go ahead.
So I just wanted to really caution us as midwives and as nurse practitioners against, as Dr. McLemore said, the idea that we're going to come in and solve a problem. We have always had abortions. We will always have abortions. So people are able to access abortion when they need to access it because communities make it happen. And so I really, really want to move us away from the idea that there are these, safety states or these refuge states, and instead really look at what's being done and what are our assumptions about what's being done in states with more restrictive laws.
Thanks. And I guess just to build on both of those comments, I also feel like, from the training perspective, we talk about abortion and contraception for all of our medical students. There are opportunities for students and residents in OBGYN and family medicine to get training. But that lends to kind of the bigger problem of who do we actually need to be providing these services where? And it's not the OBGYNs that you're seeing in small rural communities, and it's not even family med docs. It's advanced practice providers, midwives, nurse practitioners, PAs, and community providers. And so we have a system that prioritizes people with my background and similar backgrounds to mine, and deprioritizes others. There is a limited amount of hands-on training available, and we need to just acknowledge that. And that's actually gotten worse, not better, after Dobbs, because there is just not the same number of places to practice around the country. And so I really appreciate working with everyone on this call, actually, to think about how do we kind of break down some of those structures to have a more reproductive justice oriented approach that looks at who needs to be trained based on what are the needs of the people who are going to be accessing these services and what do they want. Because, even if like in a perfect world, if all different kinds of providers, community providers, nurse practitioners, midwives, PAs, physicians, were all available in a community, then that would be the best, because people could choose what type of provider was actually most comfortable for them. So we're seeing with some data that people who are choosing out of clinic abortions, it's not primarily necessarily, or even primarily because they don't have access to a clinic abortion. It's because they don't feel safe or valued in a clinic setting oftentimes, and they're making a primary choice to have an out of clinic abortion. And so I just want us to be really cognizant of that tension that justifiably exists between physician medicine and advanced practice providers. And if you look, it all comes down to abortion, as it often always does. So in the mid 1800s, abortion was actually legal. And it was when physicians started trying to codify our profession. So the American Medical Association and also the American College of Obstetricians and Gynecologists, specifically those two bodies, that deliberately pushed out midwifery, and especially Black midwives, from the practices that they were engaging in. And actually it led initially to less safe maternity care, because the physicians at the time didn't know what they were doing, and they were taking over from people who'd been doing this work for centuries, if not millennia. So anyway, I just like that little piece of history, I think also sometimes gets lost, and we need to remember that when we're looking at equitable care and patient-centered care and redesigning the systems.
Let me add to Sarah's comments there. So I work a lot with the Plan C organization, which provides online access to medication abortion. And we had a conversation last week about the people requesting medication abortion when they get a chance to choose an autonomous telehealth opportunity, or to be referred to a brick and mortar, if you will, medical provider. And 70% have chosen the virtual online option. So along with Sarah, we're seeing that data come from that experience too. And as a pharmacist, we're looking at just because we are traditionally brick and mortar, that doesn't necessarily mean that we're going to focus our activities around access to medication abortion on specific brick and mortar locations, because at least current evidence says that most people are not making that decision to access it that way. So we have much to learn. So I think the consumer is so important. By the way, I worked for Advocates for Youth for 12 years out of Washington, D.C. And young people who want to be involved in this arena, if they haven't heard of Advocates for Youth, they take lots of peer educators and young people who are interested. But we looked at low income communities of color in Washington, D.C., and looking at access to contraception, and the push in Washington, D.C. from the medical society there was to try to get as many people as possible on IUDs. And yet they were not comfortable with that. They were using birth control pills. And frankly, if you don't want a very effective, well, we think of clinically as a very effective service, but it's forced on you, you know what, it's not very effective. And people aren't going to use it. And so I was training pharmacists there to prescribe birth control pills. Medical society tried to curtail that activity, saying it interfered with access to IUDs. But we found out from the community, there was really high demand for birth control pills because their mothers had used it and they felt comfortable, and it was immediately reversible. They maintained their own autonomy. And anyway, it's really important to listen. I guess we've said that all day long here, but we need to make decisions that meet people's needs, not meet our needs as providers. Thank you.
There are a couple of questions in the chat that overlap a little bit about access via primary care and also the role of public health in abortion access in Washington. And I wanted to touch on those briefly, but I also want to make sure that my fellow panelists weigh in on this because these are complicated. One of the issues with safety net primary care providers as sites of abortion care is, of course, the Hyde Amendment, which bans the use of any federal funds for abortion care except under very specific criteria. However, Planned Parenthood has been a Title X site for decades and has also been an abortion provider. And it is possible to have simultaneous financial systems that separate out federal funds from non-federal funds in terms of provision of abortion care. That said, it can be tricky, and it requires that you have a really, really, really strong accounting system and just structures that are put in place so that it is very clearly separate. For example, I was at a Planned Parenthood in Michigan, and we could not do abortion care on the same day that we were also providing Title X services. So they were completely separate. And because of that, there was actually different staff that worked those days. So it is doable. It is a little bit complicated, which is one of the many reasons why Hyde is terrible public policy. The other piece about public health becoming involved in provision of abortion care, Heather, thank you for posing this. You're actually in luck because just before the pandemic, there was an entire 6-month-long collaboration at UCSF that looked at the role that public health departments could play in improving access to abortion care. There is an outstanding executive summary and full report from that, and I am happy to send it to you.
I'd like to comment on the Hyde Amendment also, which in my 20-some years of working with Native American populations, their funding comes from Health and Human Services, the U.S. Public Health Service. But so we've been working on looking at tribes that have alternative funding, non-federal funding, such as tribes with casinos, using those dollars to support abortion access. because the Hyde Amendment is really scary. It's scary for low resource communities to think that their primary funding for healthcare could be pulled out from under them. But by using alternative sources of revenue instead of federal dollars, that we think there's at least somewhat of a workaround here. Thanks.
But from a reproductive justice perspective, we see that as a retrofit and a temporary solution, because the truth, this is one of the reasons why All Above All is working to repeal, Helms and Hyde, because again, going back to this disparate notion and the connection that Sarah made around this idea that pregnancy has somehow been separated from abortion and contraception and other things, right? It's not that simple. And so the idea that we would have disparities in the kinds of services that people can access based on payer, that's the language we need to be using. And it gets back to this notion that employer-sponsored health insurance, which a lot of people call private insurance, but it really isn't, because it's also very heavily government subsidized. The more that we can get people to understand these constructs, I think the more it changes how we involve and engage in our political process. That said, I sent, when the federally qualified health center workaround in the state of California came forward, I sent that to Dr. Eagen-Torkko and Dr. Altman and Dr. Prager for us to start to think about how maybe we can do this in Washington state to really make sure that, in a surge state, which we're anticipating becoming, how can we make sure that there's greater statewide access to abortion services? So that's something we're also going to be thinking about in our planning year with the Actions program. I don't want another point in the Q&A, though, to get lost. And it's this notion of the language that we're currently using. There's a question that was specific to due to forced abortion states, and I think you mean forced birth states, traveling is a must for many. This can be expensive as well as abortion itself. Do you view this as states also forcing a pregnancy onto people of poverty? And somehow, wouldn't this be child abuse and or unethical? And it's really important to clarify here that the majority of patients, there is no racial or ethnic majority of patients who have abortions, but it's been widely understood that people who have abortions are poor people. It's concentrated amongst poor people. And we really need to start thinking about this idea that, if we are forcing people into pregnancies that will continue to birth, what are the essential dignified supports that are necessary? And some of us call this a robust social safety net, the human services that go along with the health side. What are we prepared to be able to develop, expand, and or modify? Because we've been having this discussion like there's not an existing maternal mortality crisis in the United States as well. So I think that needs to be named specifically. We've talked about this. Yes, pregnancy is more risky, but we already know that in similar countries, in terms of income and population distribution, that our maternal morbidity, preventable maternal morbidity and mortality rates are actually well above what they should be. So, it may feel like this is a discussion exclusively around abortion, but it's actually really around how are we going to develop a dignified system that will take care of people with the capacity for pregnancy and the constellation of individuals who are involved in their lives. That's the discussion I'm actually interested in having, because it will stop creating these false binaries. Meanwhile, we need to do all the retrofits that we're currently trying to do. We need to expand telemedicine access, and we need to make sure self-managed people, we need to do all of that. But there also needs to be a reimagining space of when do we get to start to have conversations about building that utopia that we all want to see exist? And what are the steps that we need to take in order to get there? That's the discussion I think that Dobbs has afforded us to be able to have probably a lot sooner than maybe we wanted to, but we actually can have that conversation while we're doing all these other things.
Thank you so much.
Oh, sorry.
Oh, go ahead. Please.
There are a couple of questions in the chat that I want to make sure that we address. And Monica, one of them I think that you were going to address, and the question was about essentially potential of trauma from abortion provision. And I wanted to make sure that we addressed that to be clear.
Let me see if I can't find this. I see it. I'll read it for the audience. Due to abortion having the possibility of being an emotional and can be traumatic, all parts of the process before, during, and after, time well after the process, do you believe that there is more counselors and therapists can do to help in these cases? And what would that look like? In other words, what does the future of abortion care look like in the world of social science and psychology and sociology? I would argue that there are people who have birth trauma, like there's pregnancy related trauma that people have irrespective of the outcome of pregnancy. Let's start there, which means that we need more robust perinatal mental health services regardless of how pregnancies end. So let's just fundamentally start there. The separation between physical health and mental health is another unnecessary binary that we actually could, think about using the reproductive continuum as a place to be able to reimagine not only those services, but who also are providers of care. And I think Dr. Altman said this, but there is work for everybody in this context. That's where Dobbs is also an opportunity for us, such that we could more deeply, in the same way the question was, how do we get more, abortion, i.e. procedures within, safety net institution? The actual conversation could be, how could we reimagine, physical and mental health for pregnant, capable people such that, across their reproductive trajectory, their needs are met at all aspects of the health system? That is another way of asking that question. So for me to separate out pregnancy trauma or the outcomes of pregnancy trauma is not a way to organize health services, public health, clinical health services, or policy, or ourselves, because then we will continue to create those silos in other places, and those needs won't potentially have the opportunity to get addressed in the ways they could be. One exemplar of this is being able to provide postpartum maternity care at pediatric first visits, right? Continuing not to separate that dyad, because we know that only about less than half people show up for their postpartum visit, but something like 96 to 98% of people show up for the first pediatric appointment. So that tells me that that is an opportunity for us to continue to bring those two entities back together and to design services around that. So same can be true across the reproductive spectrum. That's why we can bring doulas. That's why we can bring in community workers. That's why abortion can become part of that community of care. If we could get past the discomfort that some people feel in talking about it in that way, right? We could bring in religiously affiliated organizations and institutions. We can bring in, mental health and behavioral health providers. And we all got together and decided that the people that we serve is the focus, not the procedure, not the policy. So that's how I think about it. I think, Butch, we're going to send stuff back to you.
Yeah, sure. We have just till 1:30 allocated to this webinar. Certainly there's a lot more to discuss and a lot more conversation to be had, but this was just an initial effort to get our panelists' knowledge and perspective out there. So in closing this webinar, I note that the panelists' bios are being posted in the chat box. And I thank each of them for sharing their knowledge and perspectives, as well as our students' efforts to convey and moderate the submitted questions. Everyone's contribution to this webinar, both on screen and behind the scenes, are greatly appreciated. And just want to say again, even though we're ending the webinar now, as a follow-up, we hope to develop a web page to host resources and guidance on abortion and abortion access and reproductive justice, particularly to assist those of you in professional and clinical practice settings. There will be other discussions had, so just look out for that. We'll be sure to disseminate announcements in the following. So thank you all for viewing this webinar. And again, thank you to our panelists and students. Really appreciate your time and effort.